nervous system. Our responsibility for today is to investigate the structure and the function of the autonomic nervous system. I mean, we all heard of that, the autonomic nervous system, since pretty sure since high school. But what is it? What is the autonomic nervous system really is? So, in order to find out what is the autonomic nervous system, let's recap. What have we already learned about the nervous system, and then put in place where exactly does the autonomic nervous system fall. So we said that if we want to learn about the autonomic nervous system, then we have to divide the nervous system structurally and functionally. So we said that the nervous system, we have the nervous system, and we divide the nervous system obviously structurally. So we have a structural classification, also known as anatomical, anatomy, and we also have a functional classification, or physiological classification. So structurally, what did we divide the nervous system into? I already put two arrows. I should not have done that, but that's a hint. What did we divide our nervous system, the whole thing, the nervous system into? Excellent. So we have the central nervous system, the central nervous system, also known as the CNS, and the other one is the peripheral nervous system, also known as the PNS. That's structurally. That's like saying the company is divided into the first floor and the second floor. That's a perfect structural classification. Now we need to know the functional classification. The first floor is HR. Okay, that's functional. First floor is HR. Second floor is the classrooms, maybe. So now, what's the functional classification of our nervous system functionally? Excellent. Yeah. So we have sensory motor, but that's more like the peripheral. So, but it's good. So now I can put on the peripheral nervous system, I can divide my peripheral nervous system into sensory input and motor output. So sensory input. And what do we also call sensory input? Afferent. What kind of afferent? Is it afferent or efferent? Afferent. Very good. So the sensory is afferent, while the motor is efferent. Now that's a perfect functional classification. And what about the central nervous system? What is the functional classification of this central nervous system? No, parasympathetic, we're gonna get to this. This is today's topic. But you see here, we're doing structural. We're doing structural classification. So structurally, the peripheral nervous system has sensory input afferent neurons and motor output efferent neurons. The central nervous system is divided structurally into brain structure, and spinal cord. The brain and the spinal cord. So if I look here, I know what does my butterfly represent? This butterfly, what does that represent? What does the butterfly represent? Did we say last week? The week before? What does the butterfly represent? The butterfly always represents the, remember, I always inside the butterfly, I would draw something like this. I would draw this symbol. What does that represent? This here, what does that mean? This structure. Remember we said there is an anterior horn, posterior horn.
Interneuron? The interneuron?
Yeah, so the interneurons are here. Excellent. Yeah, that's true. So the interneurons are here. So that's part of this. But this whole compartment here, including the interneurons, very good. But what is that? That's your central nervous system. That's that's the symbol for the central nervous system. Remember we said if there is a defect in the back, you cannot sense defect in the front. That is Lou Gehrig and the example of lateral sclerosis, amyotrophic lateral sclerosis. We said, so this is our central nervous system. This is our CNS, central nervous system. That's our brain. That's our spinal cord. So that's our brain. That is our spinal cord. So this is where the integration happens. This is where integration happens. This is where integration would happen. This is where processing would happen. Integration, processing, and control. That's this here. That's all of this. That's the butterfly. That's here. So that's the central nervous system. But we said our nervous system is not only central, it's also peripheral. So peripherally is made up of neurons that take input into the central nervous system. So we make a phone call into the hospital for ambulance. We make a phone call into the police precinct for cops. We make a phone call to the fire department for a fire truck. So we have neurons that take the call into the system. So these are known as input, sensory, and as we said earlier, afferent. Excellent. That's afferent neuron. And it's always connected to the receptor. That makes a lot of sense because the receptor senses osmoreceptor, thermoreceptor, chemoreceptor, mechanoreceptor, stretch receptor. So all of these receptors are detecting some change and they're sending the input. Then when the processing here takes place, the processing and the control are happening here. We process. This person called 911, they need an ambulance. So we need to send an ambulance to this place. We need to send the cops to that place. We need to send a fire truck to that place. We need to send both ambulance and cops to that place. So this processing happens in the central nervous system. The peripheral nervous system is made up of these two guys. You see? Peripheral nervous system is sensory, input, afferent, neuron. And what's the other part of our peripheral nervous system? Yeah, so it's output, motor, efferent, neuron. And that's going from the name efferent. This one is going from the receptor, and that's efferent going to the effector. That's why we call it. So the cop is the effector who will do the effect. You need an ambulance, the effector is the ambulance. It's going to do the effect of saving your life. The police is going to be the effector. So in the body, the gland, yes, but it's here the effector. The muscle is the effector. So that's why we call the nerve carrying the information to it as effector. Now, when we look at this, something really big is missing. One more thing. So that's 3 out of 3. If I tell you describe a neuron to me at all time, you can say it's an input 1, sensory 2, afferent 3, 4, something is missing. It's a question mark in here. Here, output 1, motors 2, efferents 3, and obviously they're all neurons. But what is 4? What is missing? One thing here is missing. That's like saying our suspect is A human being who is 6'3". That's the gray area. There's a lot of things. So here, even though you think that's a lot, input sensory afferent, that's not specific enough. One more thing, you would hit the nail on the head. It cannot be more specific than that. That's what you need. What is missing? What is the one more thing that's missing? So if you think about it, if you look at these guys here are taking sensory input afferent, and these guys are bringing output motor efferent. What's that one thing that is supposed to be there we didn't write? Neurotransmitter. So the neurotransmitter is how we communicate. So here you see this gap here, this gap, we throw neurotransmitter inside the interneurons, like O'Neill said earlier. That's a form of a neurotransmitter. Even within, remember we said sometimes we have transit. We have transit that they communicate with each other through neurotransmitter. But we're describing the neuron itself. Remember we said, what are we communicating between? Communicating between tissue. What kind of tissue? I can't hear. I hear mumbling. You know the dog, he can hear from very far. I wish I could hear as good, but I wish I could. I don't. But I don't have that capability. Raise your hand, please, and tell me, give me something I can work with. You know, Adele said neurotransmitter, we work with that, but that wasn't the right answer. Nothing wrong with that, huh? Excellent, very good. Somatic or visceral, very good. So now, if I describe this as input, sensory, afferent, somatic, I know I'm bringing sensory input from my muscle, my tough tissue, my bone, my connective tissue. That makes sense. If I say visceral, so now this is not specific. I should draw two lines. So one line is somatic input sensory afferent, or visceral input sensory afferent. Because there's two of them. There's either somatic is, we said, tough tissue, right? The skeletal muscle, the bone. And the visceral is everything protected, encapsulated with bone. Like your brain is encapsulated with the calvarium. Your rib cage is encapsulated with the lung and your rib cage encapsulating the lung and the heart, and the bladder encapsulated with the pelvic cavity. So I can have, and all of them feel pain. The bone feels pain, and the heart feels pain. The brain feels pain. The rib cage feels pain. All of that. So I have somatic input, sensory afferent. I have visceral input, sensory afferent. Output, I have somatic output, motor, efferent, and I have also visceral output, motor, efferent. So that's your autonomic nervous system. This one here, this last line. So these guys, one system. Input, somatic, sensory, afferent, that is one system. Visceral input, sensory, afferent, only need one system. Motor, somatic, one system. Visceral output, motor, that's three systems. The sympathetic, that's the first one, the sympathetic. And number two, the parasympathetic. And lastly, the enteric nervous system. This here is your autonomic nervous system. This giving a motor output that's efferent for your viscera, your heart, make your heart rate go up, make your lung breathing rate go up, make your blood vessel constrict or dilate. That's your autonomic nervous system. It's the whole nervous system dealing with 1 out of 4. All of these guys, they don't need that specialization. It can stand on its own. This one can stand on its own. This one can stand on its own, but this one is your autonomic autonomic nervous system, your ANS. Is that clear?
Yeah.
This is really important.
The last one here?
Enteric. Enteric. We're gonna go in detail. So the first part of it, somatic. The second part is parasympathetic, or not somatic, sympathetic, parasympathetic, enteric. So those three guys represent my autonomic nervous system. Really important that you know this part. Who is the autonomic nervous system? It is the branch of the nervous system, specifically responsible for regulating visceral output motor efferent stimuli. Very good job. I'll give you 5 points on the exam. Your name is? I cannot hear you. Remember, I said the dog can hear very far. I cannot hear that far. Kimberly. Excellent, Kimberly. So I'm going to give you 5 points. Good job. Okay, so are we done with what is the autonomic nervous system? Where is the autonomic nervous system exactly fallen? So you see, so when we had functional classification, so that was the structural. Brain, spinal cord, sensory input, afferent, and motor output, efferent. So our autonomic would be, if I label these guys, the sensory input afferent, I should break it further into two, right? What are the two? This sensory input afferent. What should I break it into two? Sensory input afferent peripheral. What should it break into two of what? Sensory, look, sensory input afferent. It should be two of those. What are the two? Somatic and visceral, you see? Somatic and visceral. So having input sensory afferent is not enough. You got to tell me, is it somatic sensory afferent input, or is it visceral input sensory afferent? So that two arrows here should say somatic and visceral. And on the other side, I should break my motor output efferent into two branches. What are they? Give it a try. Give it a shot. You know the lottery, they play luck, they get they get their shot. What should my motor output efferent be divided into two? What? Yeah, the same thing. Visceral and somatic. Somatic and visceral.
Only difference with the visceral would be A and F.
Hmm?
The only difference with the visceral would be A and F.
Exactly. You got it. So you see, we have two of each. We have somatic input sensory afferent. We have visceral input sensory afferent. We have output motor somatic efferent. We have visceral output motor. And like O'Neill said, then our visceral now, that's gonna be our ANS, which is itself divided into three branches. What are they? And anterior. Excellent. You guys got it. I have fulfilled my job. Okay. Alrighty. So let's now, so that was structural. Functional, we said, what's the functional now? For the nervous system, what are the two functional classifications of my nervous system? We're not talking about a brain, we're talking about the nervous system. It has two functions. What are they? Hmm? I did not hear. I just heard something. I don't know what that was.
Is it the parasympathetic and the other one?
So the parasympathetic and the sympathetic are here, right here. You see? Are here. The parasympathetic and sympathetic and enteric, they're all part of the visceral, which is part of the motor output E pair. That's all part of structural. We're done with structural now. Now we're talking about functional. What could the nervous system functionally be trying to do? Functionally. Yeah, so the first part is to receive the signal and to send out the signal. So we receive signal and input, that's input. Receive signals, input, and generate output signals. Receive input, generate output. That's the PNS. What's the other branch? What's the other function? We receive input, we generate output. What's the missing part? What's this? Yeah, process. We're gonna process, integrate, because you want to process this input you got. You're sending input, you want to process it, you want to integrate the input, process, integrate, and generate an output. Generate an output. Now we have mastered the nervous system. So now let's look at the autonomic nervous system and the visceral reflexes. Okay, so the autonomic nervous system, the ANS, sorry, the autonomic nervous system, the ANS, is, you see what it says? Visceral. See what my mouse is? Visceral, motor. You see, we said that. Visceral motor, a motor nervous system that controls the gland, the cardiac muscle, the smooth muscle of the blood vessels. So the primary target organ of the autonomic nervous system, that's the target for it, is the effector, is the viscera of the thoracic and the abdominal cavities. So those viscera of the thoracic cavity is your heart, your lung, and the abdominal cavity is your stomach and intestine. That is your enteric nervous system. You know, the people, they only talk about the sympathetic nervous system and the parasympathetic nervous system, and they forget the enteric nervous system. The enteric nervous system has 5 times the neurons in the sympathetic and the parasympathetic. The enteric nervous system has 500 million neurons. The other guys, they only have 100 million. Yet they know, it's like, you know, this school, there's another school that has 5 times the student population here, nobody knows about it. So the enteric nervous system is the system that is responsible for regulating the digestive system. So when you're enjoying the food, you chew the food, you swallow it, this ripple effect, this band that moves the food down the esophagus, that electricity that is like wave peristalsis moving the food down your esophagus, that is the enteric nervous system. Then your stomach, the mechanical digest, the compression, the churning, the cutting, the chopping of the food. Who's making the stomach crumble like that? It's the enteric nervous system. Your intestine, what's making the food move through it, and what's making the intestine absorb all of this food and secrete the digestive enzymes to chop up and break down the macromolecules into micromolecules, break down the protein into amino acids, and break down carbohydrates into sugars, and break down lipids into free fatty acids and glycerol. And who's doing that? It is the enteric nervous system. And the colon absorbing the water, moving, flushing the food out of the body through the rectal canal. Who's responsible for that? The enteric nervous system. That's why some patients have Hirschsprung disease. Hirschsprung disease, yeah.
My daughter had that.
Okay, so what happens with Hirschsprung disease is that some patients are born with partial loss of the enteric nervous system. It's not complete, it's there, but there is partial a little bit that is missing. So it depends from patient to patient. Usually children are a lot better, when they are dealing with it because they are developing. They are developing, but it's for the elderly, it's when it becomes a really bad challenge. But what is the treatment? The treatment is they will do a surgery, excise, they will remove that part of it's usually the sigmoidal colon and the rectum, the last part. That's why the patient always have irreversible constriction of the sphincter. So they can never relax to let go of the fecal matter. So now what happens is they're going to excise that part and they're going to transplant. They're going to transplant a segment that is rich in the anterior plexus, and that's going to allow them for the smooth movement. But it is not that severe. It's not something. It has good prognosis. Okay, so don't worry.
Now, so it's fine.
It's fine, right?
3 months.
Yeah, so you see?
She had colostomy for a year.
And now what are they gonna do? They're going
It's
to.
reversed.
It's
It's
reversed.
Turn 1.
Yeah, God bless. Yeah. You see, always for the children because they are developing. So they have excellent prognosis. It's for the elderly. Yeah, my dad has it. Nobody discovered it except me. Even the gastroenterologist, he goes to him and says, okay, just take laxative. So the gastroenterologist is good for swiping your insurance and telling you to take laxative. They don't know anything. But from the stories that I heard, is that my mom said that my grandmother told her when she married my dad that when he was baby, he used to have a problem defecating. They used to do enema for him. I was like, hey, she's sprung. And then, yeah, it was it. Yeah. Okay. Alrighty. So this enteric nervous system is really important. And some structures of the body wall, these are the targets of your enteric nervous system. Cutaneous blood vessels, sweat glands, and erector muscles. They carry out actions that are involuntarily without our conscious intent or awareness. Visceral effectors do not depend on the autonomic nervous system to function, but only to adjust their activity to the bodily needs. So that means this gland that your your autonomic nervous system is regulating. It's not like it's just, if there is no autonomic nervous system, it's not going to work. That's not true. The autonomic nervous system help regulate, and it help to regulate and organize the process. But it is not. That's why patients with Hirschsprung disease, it's not like they cannot defecate. It's not like my father could have never used the bathroom. They just have a difficulty because the regulation part is not. It's like a patient who had gallbladder removal. So the gallbladder is there. The gallbladder does not make bile. Bile is made in the liver, but the gallbladder store it, and spray it in the proper amount. So when you eat steak, what is the usefulness for bile? If you eat vegetarian, you have no problem with. You have no problem. You have gallbladder. Doesn't matter. The gallbladder is there to release bile to help digest lipid, because the way the lipid is clumped up, so the bile spread it out. Spread it out so the digestive enzymes, the lipase, can break down the lipids excellently. So if you have a gallbladder removal, might want to ease down a little bit on the Philly steak and that kind of stuff, because you're gonna have malabsorption and indigestion. Okay, so the same thing with Hirschsprung. Your colon will work fine. It's just not as organized as it is when there's the enteric nervous system. And we've talked last time about how when a nerve is innervating a muscle, the muscle gets stronger. But when there's paralysis, that's why the people who are paralyzed sitting on the wheelchair, you see that their thighs are really thin. That was known as muscle wasting, dener, denerva, denervation atrophy. So it's like, remember we said, if you don't use it, you lose it. Because they do not get innervation and the muscle is not working, then the muscle gets weaker. In the autonomic nervous system, we're not stimulating a muscle. It's not somatic. It's visceral. We're stimulating a soft tissue, a gland. So if the gland is not being stimulated, what's going to happen? Hypersensitivity. So now we don't say denervation atrophy because we're not dealing with no muscle. We say denervation hypersensitivity. So now the gland is going to start secreting stuff crazy, hypersensitive all the time. So the visceral reflexes. So the reflexes are unconscious, meaning involuntary, automatic. They happen regularly and they do not need intervention. They auto-regulate themselves. And they're stereotype. What does stereotype mean? Stereotype reflex. So there are stereotype responses to stimulation involving the visceral receptors and effect. What does it mean when we say that the reflex is stereotype? What does that mean?
It always does the same thing.
Excellent. So the knee-jerk reflex is a stereotype reflex. If you hit the patella tendon with a hammer, you will have a knee-jerk reflex. If you do it tomorrow, your other foot is not going to jump on me. It's the same thing. It's going to keep happening over and over again. So it's stereotype. This is the visceral reflex arc. We talked about that from the first day of lecture. We said that we always have a receptor. The receptor is going to send an input signal. The input signal is going to do integration. The integration is going to generate an output. The output is going to achieve negative feedback. We're going to balance, and then we're going to achieve homeostasis. So every reflex arc, you must have all these components. So you see what my mouse is? This receptor, that's the one who's going to detect that there is a deviation. There's a deviation in the homeostatic range. There's an alarm went on. Why did the alarm go on if everything is fine? If we are within normal limits and if we are within the homeostatic range, why was there a signal will never go on if everything is fine? Only when there is hyper or hypo sensitivity. Only when there is an hyper stress or hypo stress, then a signal will come out so we can return back into EU. Remember EU. We don't want hyper, we don't want hypo, we want U. Okay. So the receptor, you see here, these are the components. You're never going to have a reflex arc unless you have these guys. The receptors, these are nerve endings that detect stretch, tissue damage, blood chemicals, body temperature, and other internal stimuli. There are afferent neurons. Afferent neurons lead to the central nervous system. The afferent neurons lead to the central nervous system. There's an integrating center. The integrating center is made up of interneurons in the central nervous system. That is the efferent neurons. Efferent neurons carry motor signals away from the central nervous system. And there is an effector. The effector will carry and mediate the effect. Could be a gland, is your heart. So this right here is the king. This reflex here is the main reflex, the most important. You know, they say the Bible got many stories, but there's that one story everybody know. Like, you know, when they throw Joseph in the well and all that stuff. This one, everybody got to know. There's so many reflexes out there. This is the king. This is the most important one you have to know. This is the baroreceptor reflex. So what happens in the baroreceptor reflex? In the baroreceptor reflex, obviously, is not a reflex unless we have these five guys. So number one, the baroreceptor, it's the receptor, you see it's all the way over there to detect a change. So what's the change? The baroreceptor sense increased blood pressure. So it increased hypertension. The next step is the glossopharyngeal nerve transmits the signal to the medulla oblongata. What does that mean? The glossopharyngeal is what is the glossopharyngeal? Is the input, because it carried from the baroreceptor to the medulla oblongata. Okay. And then the medulla oblongata in the brain, what does that make it? Here, the afferent neuron was the glossopharyngeal, right? The receptor was the baroreceptor. Who was our receptor here? It was this, the baroreceptor. Number two, who was our afferent neuron? Our afferent neuron is the medulla neuron. Excellent. The glossopharyngeal nerve is going to take our input, our sensory afferent input. Who's going to be the integrating center here? Number three, integrating center. Who is that? Excellent. The medulla oblongata is going to integrate. Who's going to do our motor output? The efferent neuron, carrying the motor signal away from the central nervous system. Who's that? Excellent. The vagus nerve is going to transmit inhibitory signals to cardiac pacemaker. And lastly, we're going to have our effector. Who's the effector? The heart. The heart is going to manifest the effect of dampening, pressing on the brake, and relaxing everything down. This battery reflex is so important. I did my master's degree on this one. They wouldn't let you do it on anything else anyways. But yeah, because this is the most important reflex in the body. And it is just so simple, yet so significant. Baroreceptor detecting increase in blood pressure, glossopharyngeal, tell the information help, too much blood pressure. The medulla oblongata send the vagus calls the nodes to drop the electric signals. No more depolarization, no more contractility, no more cardiac output increase. The autonomic nervous system has two subsystems. Is that as wrong as that is wrong, isn't that? How many systems does it have? Three. So the sympathetic and the parasympathetic, and who's the third? The enteric nervous system. So the sympathetic is fight or flight reaction. Well, either or, fight or flight, you're still stressed. Okay? Fight, you need energy, you need to, it's extraneous exercise, you're worried, your heart rate goes up, your muscles contracting, your contractility, cardiac output goes up, and you're so tense and alarmed and alert when you're fighting. When you're running away, the same thing. You're tense, you're running away, and your heart rate goes up. The parasympathetic is the opposite. It calms down. That's when you in the house, in the sofa, watching the TV, eating the pancake with the syrup, something I love to do. Anyways, all that stuff, that's the parasympathetic nervous system known as the rest and digest. It's amazing how those two were discovered by the same scientist, and he's an American scientist from Harvard. Now I know why they like that place. Very smart guy. What's his name? Walter Cannon. So he discovered the sympathetic division and he coined fight or flight. He discovered the parasympathetic nervous system and he coined rest and digest. He beat me to it. I thought I was smart. But he's dead now. So both his systems, the sympathetic and parasympathetic, are not working for now. Now, the autonomic tone. So the normal rate of activity that represents the balance of the two systems according to the body needs. So the body does not simply alternate. So remember, they're like a seesaw. If the sympathetic system is up, the para is down. If the parasympathetic is up, the sympathetic is down. But they discovered now, scientists argue all the time. They discovered, oh no, there's some times where they both work together. It's like a husband and a wife. They're always enemies and they hate each other, but sometimes they love each other.
What? Where did you get that?
One student last class told me it's the opposite, actually. Anyway, so the parasympathetic and the sympathetic, they are the opposite. But sometimes they are friends. And we will see that one. We will see how when they work against each other, like for example, your heart. When you need to run, obviously sympathetic has to make you pump because you need a lot of blood to your muscles, you need a lot of ATP, a lot of glucose so you can run for your life and survive. But when you're relaxing, the para is gonna shut down the heart and preserve your heart and prevent it, dampening it, preventing it from like moving as fast. Okay, so that's an example of dual innervation. So both are working, but one time this it's like a dad and a mom raising a baby. One gives a push, the other one is a pull. Stuff like that. Yeah, that's how we were brought up. One is the one. My dad was the sympathetic, and my mom was actually it's the opposite. My mom was the sympathetic. My dad was the parasympathetic. Yeah. So that's how it works too. So the heart is the baby of your sympathetic and the parasympathetic system. They regulate it based on different circumstances. So the autonomic nervous system has components in both central and peripheral nervous system. So now we're gonna learn this concept of ganglia. So the ganglia is like Grand Central. You go in that huge station. One can take you to Penn Station. One can take you to Buffalo. One can take you to the Mars. One can take you all over the place. That's how the autonomic nervous system is. You don't have just one. You see here, we drew a very simple one long line. But all is not like that. There is a big Grand Central here in the middle, so each one get to cross. Okay, so that's known as a ganglia. There we go. So if you are before Grand Central, before the ganglia, we call you preganglionic. But if you are after Grand Central, after the ganglia, we call you postganglionic. But in the end, pre or post, in the end of the day, you are still what? No, you're not still ganglion. You're not. You're going to the ganglion, it makes you pre-ganglionic. Leaving the ganglion makes you post-ganglionic. But in the end of the day, you're what? The ganglia, guys, is the station, Grand Central. If you go into Grand Central, are you Grand Central? No. No, you're going in there. So that's what you're saying when you say that you're a ganglia. So the neuron goes to the ganglia, makes you preganglionic because you're heading to it. When you get in there and take the other ride, that makes you postganglionic. Excellent. But my question is still unanswered. Whether you are preganglionic or postganglionic, in the end of the day, you're still a neuron who is visceral motor, carrying visceral motor efferent information. So you're never going to see a sensory preganglionic or a sensory somatic preganglionic or a somatic motor ganglion no. That ganglia stuff only for the autonomic. Okay? So let's look at the somatic. This is the somatic. Do you see a ganglia here? There's no ganglia. That is your computer, your integrator, your processor, your spinal cord sending out an efferent or afferent. That's the muscle. So if this guy is heading to the muscle, what is that? That's efferent. Is it somatic or visceral? Somatic is going to the muscle.
Yeah.
What would you say visceral? It's somatic.
The heart, lung.
Visceral glands and organs.
Yes, soft tissue. Yeah, hard tissue, bone, skin, muscle. So everything not protected with a bone. Is the skin protected with bone? Skin is protecting the bones. Skin is on top of the bone. But it is the heart who is protected by the bone. It is the bladder protected by the pubic symphysis, by the pelvic girdle. Okay? It is your brain protected with the calvarium, with the skull cranium cap. So this here is an example of somatic motor. This is non-negotiable. You see, that's somatic. We're dealing with a muscle, and that's the computer, and that's the neuron output. So that's a efferent, motor, output, somatic. Now, when you look at that, do you see a ganglia? Do you see grand central here? Yeah, it's this yellow one. Do you see a grand central down here? Yeah, it's right here where my mouse is. It's a little bit far. So that's the difference now when you look. You see in somatic, no ganglia. In sympathetic and parasympathetic, each one has their own ganglia. So remember what I told you. If you want to tell the difference between two things, begin with the similarities. What is the difference between the ganglia of the sympathetic motor and the parasympathetic motor? First of all, both of them have preganglionic and postganglionic fibers, and both of them have ganglia. The only difference is the sympathetic has short you see the green one is short preganglionic fiber and long unmyelinated postganglionic fiber. So going out the computer to the ganglia in the sympathetic, you're short and myelinated. Leaving the ganglia, you're long and unmyelinated. For parasympathetic is the opposite. Getting to the ganglia, you're long unmyelinated. Leaving the ganglia, you're short and unmyelinated. That's the histological difference. Both have ganglia, but one has long preganglionic, short postganglionic. The other has short preganglionic, long postganglionic. Do you see? Look at the sympathetic. The sympathetic has short preganglionic. You see where my mouse is, everybody? The sympathetic has short preganglionic, then a ganglia, then long postganglionic. And then the parasympathetic has long preganglionic, but really short postganglionic. And whether you're sympathetic or para, the postganglionic is always unmyelinated. This red one is always unmyelinated, while the preganglionic is always myelinated. We're almost there. Keep it up. Keep it up. Okay, the sympathetic nervous system has a nickname, thoracolumbar. Why is that? Because it comes from there. You know the rapper, he's saying, Harlem, Brooklyn. That's where he's from. So these guys, they say that. These guys, the sympathetic, they call the thoracolumbar. That's repping where I'm from. Yeah, that's what it really is. So they say the thoracolumbar, if you look here, its pathways arise from thoracic and lumbar regions of the spinal cord, so also called thoracolumbar division. Okay? Fat Joe the Bronx. Yeah. So this one, the sympathetic, is the thoracolumbar. It comes from there. It's not found anywhere else. It is found all over the body, but originate from there. That's the headquarters. It disperses. You know the plant that goes in the trees and the houses and climb? It has a place to start from, and it climbs all over the place. Same thing, sympathetic nerves. They climb all over the body, but they originate from the thoracolumbar, from the thoracic and the lumbar region. There you go. That's where they are. Thoraco and lumbar. This box here, thoracic and the lumbar part. You see, thoracic is blue, lumbar is orange. All these blue, orange, that's where all your sympathetic nervous system coming out. All these cilia, ganglion, they have different names. They don't say just say grand central. There is the cilia, ganglion. There is the Penn station. There's the, but they're all part of your sympathetic nervous system. Okay, this is really important. You see the medulla. If you ask anybody what is the medulla is the ganglion. If you actually, which medulla? You know, people say the medulla. There's many medulla. There's the medulla oblongata. There is the medulla of the kidney. There's the medulla, the adrenal medulla. So you're gonna hear this medulla, medulla, medulla all the time. But you have to know what is it. Medulla always means the core in the middle, and cortex means the roof. That's why they say the cerebral cortex. That's the roof part. The medulla oblongata. That's the middle part. They say the kidney nephron, medullary cortical nephron. Cortical means the roof. Medulla means the core. So we have adrenal medulla, adrenal cortex. So now you have to know this adrenal medulla and the adrenal cortex. Okay, so this is the kidney. You have paired two kidneys. They're not like your ears. They're not so in line. So your ears, the right one and the left one, they're like that. But the kidneys, one is a little bit depressed while the other one is on the top. Why is that? Why is it? Because who's pushing it down? The liver. On the right side, your liver is pushing your kidney, so it's a little bit tilted to the bottom. But either way, tilted or not tilted, there's always a hat on the top. A hat on the top, like this. This is known as the adrenal gland. Now the adrenal gland, if I take it out, this triangle, if I take it out, I'm going to see that this triangle could be divided into two segments. A segment in the core, known as the medulla, or the adrenal medulla, and all of this is known as the adrenal cortex. Okay, the adrenal cortex is further divided into three layers. 1, 2, 3. 1, 2, 3. The first layer is known as the zona glomerulosa. Glomerulosa. Glomerulosa means balls, circles. The reason why they call it zona glomerulosa is because they took a histological section and they examined it in a microscope. They saw that it looks like rounded balls. So they call it in Latin, granulosa means balls. And the zona glomerulosa secrete the mineral corticoids. The mineral corticoids. So the mineral corticoids are your aldosterone, like your aldosterone. The middle layer is known as the zona fasciculata. fasciculata. What is the zona fasciculata? Fasciculata means sticks, sticks. So when they took a histological image, sticks, bundles, like this, 1, 2, 3, bundle, bundle, bundle. They look under the microscope, they look like sticks and bundles. That is the zona fasciculata. What does it secrete? They secrete glucocorticoids, like the cortisol, glucocorticoids, known as cortisol. And lastly, you have the zona reticularis. The zona reticularis is called the net. Reticularis in Latin means the net, because they look in the microscope, it looks like net. So if the zona glomerulosa give us mineral corticoids, the zona fasciculata giving us the glucocorticoids, the zona reticularis give us the gonadocorticoids. That's why when they look in the blood work of a man, they see a little bit of estrogen, he has no ovary. They look in the body of the woman, they see a little bit of testosterone, she has no testes. Who's making that? The zona reticularis in your adrenal gland. Because you need a little bit of both. If you're a man, you have your essential hormone, testosterone, but you need a little bit of estrogen. If you're a female, you need the essential hormone, estrogen, but you need a little bit of testosterone as well. The adrenal medulla, that is our sympathetic now. The sympathetic has nothing to do with corticoid. You see that? Mineral corticoid, glucocorticoid, gonadocorticoid. That has nothing to do with our sympathetic, parasympathetic. That's to do, the corticoid is going to help during that state of stress. But where does the epinephrine and norepinephrine come from? Norepinephrine and epinephrine, they come from the chromaffin, these chromaffin cells in your adrenal medulla. That is where they say adrenaline, it comes from there, from that inner adrenal medulla. This one in the core, they are the ones who secrete. So if you look in the slide, the outer layer secretes steroid hormones. All of these corticoid, glucocorticoid, mineral corticoid, gonadocorticoid, they are all cholesterol, made of cholesterol. While the adrenal medulla is not making cholesterol, they make catecholamines. So they make, these are the ganglion, you see they make catecholamines. They secrete a mixture of hormones into the bloodstream. The catecholamines, 85% epinephrine and 15% norepinephrine. Now these are the cranial nerves. The cranial nerves, if you look here, what do the cranial nerves do? Parasympathetic fibers leave the brain stem. Is that shocking? Is that a surprise that they leave the brain stem? They leave the CNS? They leave the computer? They leave the control center? The processing center? No, that's what we're doing in this lecture. Autonomic meaning leaving, efferent, motor, output, visceral. So they leave the brain stem. What do they target? Should they be targeting tough tissue or soft tissue? Soft tissue. So there you go. You look. You see where my mouse is? Oculomotor nerve thickens the lens, narrow the pupil of the eye. Is the pupil of the eye visceral or somatic? Visceral. That's what we're doing in this lecture. Visceral. Excellent. Facial nerve. It takes from the brainstem to the tear, nasal, and salivary glands. You see, that's visceral. Then glossopharyngeal, they go from the brainstem and they regulate parotid gland. You see, they target soft tissue, all of them. The vagus nerve, innervate the viscera as far as the proximal half of the colon, cardiac, pulmonary, esophageal plexus. You see, all of it, viscera, from brainstem to viscera. Now, that's the anterior plexus. We talked about that. We talked about how the anterior plexus is important for digestion. Composed of 500 million. neurons found in the walls of the digestive tract. There are 5 times more neurons than the spinal cord. Hirschsprung disease is a hereditary defect causing the absence, congenital absence of the anterior plexus. No innervation in the sigmoid colon and the rectum. So it causes premature permanent constriction and will not allow the passage of the feces. So the feces becomes impacted above constriction. The megacolon. The megacolon is a massive dilation of the bowel, accompanied by abdominal distension and chronic constipation. There may be colonic gangrene, perforation of the bowel, and infection of the peritoneum. These are the neurotransmitters. You have acetylcholine. And everyone that is dealing with acetylcholine, we call these neurons who deal with it the cholinergic because they deal with acetylcholine. What about the ones who deal with norepinephrine, adrenaline? What do they call that? Adrenergic. If you're dealing with acetylcholine, cholinergic. If you deal with adrenaline, adrenergic. The receptors of acetylcholine on a cardiac muscle, smooth muscle, these are known as muscarinic because they were found on a mushroom, the muscarinic mushroom. While nicotinic receptors, they are found on the postganglionic neuron cell bodies in the autonomic ganglia, on the cells of the adrenal medulla and the neurotransmitter neuromuscular junction of the skeletal muscle fibers. These are the adrenergic receptors, and these are the beta adrenergic receptors. So here you see that you have, even though you have 2 adrenergic receptors, they do the opposite. So the alpha adrenergic, they cause excitatory synapses, while the beta adrenergic, they cause inhibitory synapses. So you see, these are the cholinergic. You see the parasympathetic cholinergic postganglionic neurons, they secrete acetylcholine, and the acetylcholine stimulates postganglionic neurons. And the postganglionic neurons, they secrete acetylcholine that's going to bind muscarinic receptors. Acetylcholine is secreted from preganglionic neuron, is going to bind the postganglionic neuron that is going to secrete norepinephrine. So acetylcholine, when it binds its receptor, what does it do? What does acetylcholine do when it binds the receptor? What does ACH do when it binds the receptor? Let's say I have 2 receptors. One receptor is going to bind acetylcholine, ACH. What's going to happen? The channel is going to open. When you open the channel, what's going to happen to the electrolyte influx? You're going to have an influx of sodium. You're going to have an efflux of potassium. That's the action potential. That's membrane voltage change. But epinephrine doesn't do that. Epinephrine, when it binds its receptor, norepinephrine, it's not a channel. It doesn't allow for the entry of nothing. What it does is it will bind a G-coupled protein receptor. So when norepinephrine binds the G-coupled, then you're going to have a downstream. You will have a downstream signal transduction cascade that's going to trigger a second messenger, and the second messenger is going to give you the target effect. So no action potential. No action potential with norepinephrine. Norepinephrine is a G-coupled protein that's going to do a cascade to give you a target effect. Give you a target effect. The dual innervation, we talked about that, how parasympathetic and sympathetic, both of them are both affecting the same organ, the heart. Sometimes making it go faster, sometimes making it go slower. So your eyes, there's dual innervation the same way the parasympathetic and the sympathetic, they affect your heart, they also affect your pupil. So the parasympathetic nervous system causes what to your pupil? Constrict or dilate. It's written over there, you can look at it. It makes it constrict. Usually the parasympathetic is the relaxer one. Parasympathetic is going to make the blood vessel diameter wider, and usually the sympathetic going to constrict the blood vessels, not the eye. The parasympathetic relaxes the eye, constrict the parasympathetic relax the pupil, the parasympathetic constrict the pupil, and the sympathetic relax, dilate the pupil. We see that here with the blood vessel. So sympathetic tone, the arrow point inward. So we crush down, we make the blood vessel diameter go smaller. Vasodilation is when we increase the diameter.